Topbed Talk.
Delighted to introduce the next speaker, Linda Denehy, a good friend and colleague. She is a professor of physiotherapy at UOM and registered physiotherapist. She has a joint appointment of Professor of Health Service Research at Peter Mac in Australia. And I'm very much looking forward to your talk because we think it's really important to look at prehab in respiratory patients. Thank you.
Thanks, Sandy. Today I'm going to be talking about respiratory prehabilitation, and no nice new data or anything, but just a review. I know I'm preaching to an audience here that knows quite a lot about post-op pulmonary complications, but as we know, both the definitions and the incidence will depend on how post-op pulmonary complications, or PPC as I'll call them from now on, depend on the way it's measured and the risk level of the population that's studied. But this definition here is from Abbott, and they have a severity scale as well for PPC. For patients developing a PPC, though, the outcome is usually an increased length of stay by around about a week, but maybe a little bit more, poorer post-operative recovery, later return to oncological management, and increased mortality at 30 days and at 12 months. So what interventions can we use to reduce post-op pulmonary complications? Well, clearly, multidisciplinary prehab that we've been discussing for a day and a bit now is shown in many papers to reduce post-op complications and post-op pulmonary complications. Today, though, I'm going to be speaking about breathing exercises and inspiratory muscle training, fairly briefly. So firstly, what's the current evidence for each of these interventions for reducing post-op pulmonary complications? Well, as you can see, there are now a plethora of meta-analyses, and they do reflect quite a few RCTs rather than too many meta-analyses and not enough RCTs, particularly across thoracic and abdominal surgeries. But there's also a growing number in orthopaedic surgery as well. So this slide represents some of those, and along with two recent overviews of systematic reviews, each containing 55 systematic reviews, one by McIsaac from Canada, in different surgeries, and one, the last one there from our group, containing 30 randomised trials in an overview in thoracic surgery. So I think these provide, evidence that the evidence in prehabilitation and the volume is really growing and has grown over the last, 5 to 10 years that we've been looking at prehab more in a sort of research sense. But notably, the most relevant reviews to the impact of respiratory prehab alone on PPCs come from this paper in 2020 by Odor et al. And this systematic review includes 30 RCTs reporting the significant influence of ERAS and pre-op physio, and you can see that I've underlined them here and circled the fact that they both sit outside and just don't touch that line. So they're both significant, and respiratory physio in this was defined as breathing exercises, inspiratory muscle training, early mobility, and involved 12 of the 30 trials in the systematic review. In this review, these interventions presented moderate levels of evidence using the grade criteria, which is actually pretty good for grade because most grade criteria are around the low and very low. Similarly, in this review by Perry, both from the UK, by the way, in a large systematic review of 178 RCTs across all major surgeries, including orthopaedics, cardiac, thoracic and abdominal, they reported 5 studies in inspiratory muscle training alone and 4 in exercise prehab. Sorry about the quality, but this is straight from the journal. And they reported that both reduced PPC by about 46%, and also similar to note from Odor that the IS in there is incentive spirometry, and as you can see that's not significant in this meta-analysis. For reductions in hospital length of stay, again, inspiratory muscle training and multimodal interventions were significant in reducing length of stay by nearly 2 days. Now, length of stay findings do differ across RCTs and systematic reviews, so they don't always look that good in my reading. Multimodal prehab here included respiratory and exercise, whole body exercise, with diet and psychology when appropriate. These data also provided moderate levels of grade evidence. So what's included in the two respiratory approaches? Firstly, respiratory prehab with breathing exercises. In physio, we used to actually see everybody before surgery and talk to them about what they needed to do. And then pre-admission clinics came, pre-anaesthetics clinics came, in Australia certainly, and then the physios didn't actually see the patients anymore beforehand. But that's coming back now because of evidence. So in physio, we sort of call this talk, walk and breathe. So we give education about the risk of developing the PPC, explain why getting out of bed and walking early is important. We teach and demonstrate the active cycle of breathing techniques, ACBT, and I'll talk about that in a minute. And patients are often given a booklet, but we have shown in an RCT in Australasia that a booklet alone is not as effective as a face-to-face session or one-on-one 30 minutes consultation with a physio. We also know from that work in our qualitative research that patients actually remember the deep breathing intervention. And that could be because of the physio who was doing it, who's larger than life. There's certainly got something to do with personality, but we do know that they remember the exercise that they're given beforehand. We also, in the blurb, when we talk to patients, give them memory cues for when they wake up, give them a job, get them to practice, so that when they wake up in recovery, the first thing that comes to their mind, hopefully, is that they need to do some deep breathing exercises. And, that's really important. And also, in a recent study, soon to be published, in emergency abdominal surgery populations, we've shown the number of sessions of supervised deep breathing exercises within the first 2 post-op days is associated with a further reduction in risk of PPC. And that was in nearly 300 patients. Most of the reduction occurred within the first 2 to 3 supervised sessions within the first 2 days. So it doesn't really take that long at the bedside to do a couple of sessions of deep breathing exercises. ACBT is not new. We've been teaching, or there have been across the world teaching in physiotherapy programs for about 40 to 50 years. What has changed, though, as I said, is that patients no longer have this in the hospital, but they need to have it in their pre-admission clinics. So that's a resourcing issue for physiotherapy departments. ACBT, as the name implies, is a cycle. So it's a cycle of relaxed breathing, deep breathing, huffing, which is like fogging up a mirror, like that, and coughing. And the cycle does vary, so the number of deep breaths might vary from 4 to 10. I don't know about you, but if I do about more than 6, I get a bit dizzy. So patients do get dizzy, so you have to individualise that a little bit with a breath hold at the end of each of the deep breaths. And the most important for surgical patients, the most important part of this ACBT cycle is the deep breathing. And it needs to be done in sitting up as high as possible to make sure that your functional residual capacity is as high as possible when you do that. So sitting out of bed in the chair is the best position for ACBT after surgery. It's also used in airway clearance, and there the huffing and coughing, you use that a bit more because there's more secretions to bring up than generally in surgical patients. So while there's we have evidence for face-to-face respiratory prehab, COVID, of course, prompted having to use video conferencing. And at Peter Mac, we pivoted to video conferencing, and we call this surgery school and reflects the surgery school concept from Manchester here in the UK. We use 6 core videos, and I've circled here the respiratory one, and that the script sort of follows what I've actually described, but also includes oral care. The delivery method has benefits, of course, if you're doing this by video conferencing or telehealth. Rural and more distant patients can join, family can join, the videos can be rewatched. We also include in this course set a description of ERAS, nutrition, pain management, psychology, the benefits of exercise when patients go home. These can be added to. This is the core set. We've recently started some prehab for patients from gynae oncology surgery, and we've added a video on pelvic floor muscle function and exercise, and in head and neck cancer on tracheostomy care and so forth. So you can add to these videos. While we've evaluated the feasibility and acceptability of these webinars, so it's not just giving the patient videos to watch. We actually run these through a webinar that's hosted by our ERAS nurse at Peter Mac. And while we know that it's feasible and acceptable to patients, the efficacy of the video prehab education as part of the package of prehab care and reducing PPC has not yet been established or studied. What about IMT? So it's been mentioned a couple of times. So it's repetitive resistance training using a device that you can see here. Where is it? Okay. So you can see on the far left there, that's a spring-loaded device. It's a Phillips threshold device, and it's just targeting the skeletal muscles, so the inspiratory muscles, and increasing the load on those muscles by generating the resistance. There's also a digital device there as well. So the Philips device is half the price or a third of the price of the digital device. But in Australia, we actually can't get any of the Philips devices at the moment. So it's a bit difficult. So what happens with inspiratory muscle training, very briefly, is that you work out the dose based on the maximal inspiratory pressure measured from residual volume using that small device there, a micro RPM, to set individualised doses. And the Kendall reference is really good for looking at dosing of inspiratory muscle training. It involves somewhere between 15 to 30 breaths twice a day for 1 to 4 weeks, generally for 2 weeks. And as we've discussed, probably a minimum of 2 weeks, but we don't really know yet. And it's a shame that IMT obviously was not shown to be successful. One, it might include improved MIPS. It really has been shown in quite a few systematic reviews to improve post-op pulmonary complications alone. So this is just looking at IMT. But it does need to have some contact. So rather than just, I think, giving the device to a patient and letting them go, it really needs some contact either on the video conferencing or a face-to-face to increase the dosage if that's needed and to set that dose. There's excellent evidence for IMT in preventing PPC in thoracic and, in cardiac surgery, but sadly not in the one just presented, but certainly from the meta-analyses, but in fact not to date in abdominal surgery. And, there was the INSPIRE trial run here, and led by Denehy. We've been just waiting for that to come out. So that's looking at IMT across different surgeries, cardiac, thoracic and abdominal surgery. And I was just speaking with Denehy, and unfortunately that trial had to be stopped or was stopped by the NIHR, but there's still quite a few patients. So it'd be great to see those results coming forward, especially in abdominal surgery, because there's very little evidence so far in that. So that should be hopefully fairly soon. But also importantly, I think you can combine IMT, and that whole body training plus IMT has actually been shown to improve the certainty of PPC reduction. So we have the evidence for these easy-to-implement techniques of respiratory prehab, but is it value for money? And we talked about this a little bit yesterday, and this will be a very quick squiz through a difficult concept, and it's quite hard to sort of get your head around quickly, but I think the answer was a tentative yes. It's highly likely to be value for money. We ran a formal cost-effectiveness analysis alongside our RCT in over 400 patients in Australasia, and the results actually fell across the two right-hand quadrants on this simplified cost-effectiveness plane, where the best result is the bright green one at the bottom right-hand quadrant, and the one above it, there will be trade-offs, but, that's not too bad. So I'm just doing this really, really basically. And what you're seeing there is the purple square, and that is the cost effectiveness as given by the experienced physios. So when the experienced physios did the prehab, it seemed to work better. And the blue circle is for all physios. So there were 7 different physios who actually provided the respiratory prehab in this trial. So we actually know that it was shown to have a 95% probability of being cost effective, and that the net benefit to the hospitals was around about 5,000 Aussie dollars, which really worth that much. So about 250, halve that for pounds, and for each PPC prevented. Unfortunately, for the cost utility for the quality adjusted life years, which is more the patient end of what's happening with the patient, was less certain at 73%. And obviously, we need more work to be done on that. We have estimated, though, in some further work that's been led by my colleague Ianthe Bowden, that will be published in the next little while, that one session of respiratory physio plus the post-op breathing exercises costs the hospital around $400, and that we estimate that a PPC costs the hospital about $29,000. So it's got to be value for money. It really does. So for completeness, though, there are other breathing techniques that could be taught in respiratory prehab. Incentive spirometry, and at the moment there's no high-quality trials or meta-analyses that support the significant effects of this, but perhaps it's reasonable to consider the addition of an incentive spirometer if a patient is limited in their ability to take self-directed deep breaths. Similarly, for prophylactic non-invasive ventilation, you can see here results from the evidence from application in a systematic review from our group that includes the large RCT from Rupert Pearce, and that prophylactic NIV does not impact development of PPC either. So, from a preoperative advice and education perspective, we have robust evidence from a number of clinical trials that respiratory prehab is effective. It's easy to implement, low risk, low cost, and we think it's value for money. We have evidence that it's memorable to patients when delivered prior to surgery from our qualitative research. So, where does that fit into the model of prehab care? So this might be something that would be interesting to discuss. I think that respiratory prehab could easily fit into universal care if you're a believer in universal care. But certainly if there's not enough resources, then patients at high risk of developing a PPC, as assessed by a risk tool such as ARISCAT, should have respiratory prehab. And the blue and the red may be respiratory prehab plus prehab or whole body exercise. And for perhaps cardiothoracic, so cardiac and thoracic surgery, that the breathing exercises could include also inspiratory muscle training. But I think that they fit somewhere that is more universal, but can be combined also with whole body exercise. Just our patients have, left us some really lovely quotes, just to finish with these from surgery school in the blue, and the ones where we were teaching people about the fact that we probably use the word pneumonia, not PPC, because patients understand that better. And it was the one thing that this patient didn't want to have. And that it just really speaks to the empowerment, I think, that the patients get from hearing a session of respiratory prehab. Thank you.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.